We've got a chest radiograph of a skeletally mature patient. At first glance, what jumps out is the right-sided subclavian venous catheter, which looks to be in a satisfactory position in the lower superior vena cava. No issues there. But immediately I notice something unusual. There's gas outlining the left heart border and the descending aorta. This is a telltale sign of pneumomediastinum. The streaky shadowing at the left lung base and loss of definition of the left hemidiaphragm also catch my attention. This could potentially represent free gas below the diaphragm, and that makes me think about pneumoperitoneum. We also see contrast-filled bowel outlined by gas laterally, again consistent with pneumoperitoneum. What's important here is that there's no gas evident in the neck and no pneumothorax, which are details I'm actively checking off my mental list as I go through this. This rules out a cervical source of air or a pneumothorax contributing to the mediastinal gas. Now, taking a look at the contrast swallow images, things become clearer. There's an obvious area of contrast extravasation from the right side of the distal esophagus. This suggests an esophageal perforation, and the esophagus itself appears narrowed at the site of the leak. If this wasn't a spontaneous perforation, then it's possible there was an underlying stricture that gave way. A stricture or spasm could explain why the esophagus is narrow at this point. However, the fact that there's extravasation seals the deal. It's a perforation. What could cause this? I'm considering two possibilities. One, this could be iatrogenic, especially if the patient recently underwent an endoscopic procedure, particularly one involving dilatation of an esophageal stricture. That's a known risk factor. Or, alternatively, we could be dealing with Boerhaave syndrome, a spontaneous esophageal rupture, though that classically follows vomiting, and I'd need to check the history for that. At this stage, we've got pneumomediastinum, pneumoperitoneum, and clear extravasation of contrast from the esophagus. All these findings point towards an esophageal perforation. The distribution of free gas supports the diagnosis, and I'd say this is likely iatrogenic, given the appearance of the narrowing and the absence of classic signs of spontaneous perforation, like a history of vomiting. Now, if I were being examined, the key question here would be about the next steps. Immediate consultation with a surgical team is crucial because esophageal perforation is a surgical emergency. Depending on the patient's clinical stability and the extent of the perforation, the management could range from conservative treatment to surgery. Imaging, particularly a CT scan, might be necessary to assess the full extent of the mediastinal and abdominal involvement. I'd also be prepared for questions about differential diagnoses. We've ruled out things like pneumothorax and cervical sources of air. Boerhaave syndrome, as I mentioned earlier, is still a possible differential if the history of vomiting is confirmed, but without that, iatrogenic perforation seems more likely. So to wrap up, we've walked through the findings systematically: pneumomediastinum, pneumoperitoneum, and extravasation on the contrast swallow, leading us to the conclusion of an esophageal perforation, most likely iatrogenic in this case. Thank you for following along. For more deep dives into complex radiology cases, stay tuned and don't forget to subscribe to Radiology Made Easy for more focused, easy-to-digest learning sessions. See you next time.